I've been involved with quite a bit over the last year, and I think brings a lot of value to a health system as a whole and improves patient outcomes quite a bit. So that's ERAS, which you might have heard talked about at a conference. You might have heard mentioned around the hospital briefly. It stands for Enhanced Recovery After Surgery, and we'll kind of go into the specifics of it during this presentation. So our objectives for the presentation, at the end you should be able to describe briefly the history, kind of how ERAS developed, also discuss the benefits and basic concepts of what an ERAS protocol is and what it does, describe some of the basic medications that are utilized, and then also understand the current initiatives that are going on at our health system and future expansion. I have no disclosures for this presentation. So within GI surgery, historical management broken into three realms, pre-op, intra-op, and post-op, looked quite a bit different than it does today. Preoperatively, prolonged fasting and mechanical bowel prep used to be universally practiced with the goal of being sure that there was nothing in the GI tract that was going to be operated on and could potentially contaminate the field, and also to reduce the risk of aspiration. Intraoperatively, NG tubes and surgical drains were used a lot more, and liberal fluid and opioid administration was pretty much the standard. And postoperatively, prolonged bed rest and delayed resumption of oral intake so as not to stress the new sutures. In the early 90s, ERAS principles began to emerge specifically within colorectal and some fast track within cardiothoracic surgery. The couple goals related to this, reducing the stress response to surgery is one of the principal goals. Also attempting to reduce the incidence of complications, and then accelerating the recovery process as a whole. So as ERAS protocols were further developed and modified over the following years, 25 to 30 years to present, there was one fundamental or principal goal that everybody kind of abided by, and that was to reduce the endocrine and metabolic stress response to surgery. Since surgery is a very catabolic, stressful event to the body, the goal was kind of to see how we could mitigate those responses and reduce the stress response physiologically. So as far as the description of ERAS protocols, first they're patient-centered. The patient is really the focus, and all the healthcare providers kind of center around that. And the patient, not necessarily the quality of the patient and the quality, not necessarily the duration of the recovery, is really the focus of the protocol. The protocols are also based on the most recent and well-substantiated evidence that is available within the literature at that point in time. So these protocols are pretty fluid, and they're modified consistently. They're standardized and protocol-driven. So standardized in an effort to provide a framework for consistent care delivery, but they're never intended to force a provider's hand or to limit their ability to modify or change aspects of a specific protocol as they see fit to deliver the best care to a patient. They're multidisciplinary. They involve every area of the hospital, from nursing to social work to surgeons to anesthesiologists to physical therapy. Really every aspect of the care model is involved. So the big question is, why do we really care? So the benefits of enhanced recovery protocols have been prolifically published and written on over the last 20 years. Some of the main, benefits that people have reported are reduced length of stay, reduced complication rates, significant reductions in opioid and analgesic consumption, and what administrators like to see is a reduction in cost. We also see an increase in patient comfort. And one of the things that I didn't realize till I was preparing for this talk, how significant it was, is that there's a very commonly reported increase in patient satisfaction with their overall care and their likelihood to report that to friends and relatives and recommend that hospital to their family members. So one specific study that I want to talk about briefly, and was based out of the University of Virginia, published in the Journal of American College of Surgeons back in 2015. They look at 98 traditional care pathway patients, and they compare them to 109 enhanced recovery pathway patients. So a mean reduction in length of stay of 2.2 days, from 6.8 to 4.6, or 32% reduction. All-cause surgical complications reduced from 30% to 14.7, And surgical site infections specifically, when they looked at those, were reduced down to 7.3% from 20.4. So pretty dramatic results. This is a graphical representation of the data that I was telling you about, specifically looking at length of stay. The reason there's a gap in the middle of that graph is because they wanted to delay 6 months from when they started implementing this process, so they didn't get providers altering their management once they started talking about and discussing how they were going to change future management. And you can see the blue line up at the top is the length of stay for colorectal surgery, and down at the bottom is after ERAS implementation. So it decreased quite substantially. The cost, which everybody always wants to hear about, roughly $6,500 per patient. So $25,000 hospital stay down to $18,700. So total cost savings for that enhanced recovery group, almost $800,000 via roughly 109 patients. And then something that I thought was pretty interesting was the Press-Ganey patient satisfaction scores, which have gained more and more importance over the last couple years. Patients were happier with how they were cared for. They felt like the providers were more intentional and focused on their recovery process. Their overall satisfaction went from 26 to 59%, and they felt more ready to go home despite staying for a shorter amount of time. And their likelihood to recommend the hospital to other family members or other friends went from the 32nd to the 89th percentile. So opioid reduction has been something, it's been a big topic of conversation over the last several years, specifically in the last 2 or 3 years. And one of the things that these enhanced recovery protocols show is a consistent reduction in opioid consumption. This one study decreased opioid morphine equivalents roughly 80% in their patients. Now, if you look, this chart is a little bit busy, but we'll kind of focus on just a few key points here. Wanted to show you just kind of a numerical representation of the reduction in morphine equivalents. So you can see here, just intraoperatively, they started about 21.7, went down to almost 0, 0.5. And if you look at total morphine equivalents for the hospital stay, almost 281, down to roughly 63. And the other important thing, which we're learning more and more about as time goes on, is the reduction in fluid that's administered during a hospital stay. We learn more and more about the outcomes and how outcomes deteriorate the more fluid patients receive beyond what they actually need. And so if you look both intraoperative and total net fluid balance for the hospital stay, instead of getting 2.7 liters, they're getting less than a liter intraoperatively. And then if you look at their total hospital stay, they're almost euvolemic by the time they left compared to how they came in. And all of this benefits and enhances their recovery, helps them get out of the hospital faster. And then the other thing I wanted to point out is down at the bottom here, how many patients actually got out of bed the day of surgery? 0 before, 84 after. And the more and more you look at research in general and recovery after surgery, it talks about getting patients up, mobile. A supine patient is in the worst position they can be, so you at least want them sitting up in a chair, and their goal was to get them out of bed that first day post-operatively. So we're talking about opioids and reasons to avoid them. There's many, many reasons to do so. Sedation and altered level of consciousness obviously will make it difficult to get out of bed, to ambulate, to get out of the hospital faster. Also keeps patients from oral intake if they're nauseated as a result of those opioids. Respiratory depression, resulting in decreased level of consciousness, decreased respiratory effort, increased risk of infections, specifically pneumonia from atelectatic lung tissue. One of the next complications is increased incidence of post-op nausea, vomiting, which has been extensively documented within the literature. There's a direct correlation with that. You give somebody opioids, they're going to get nauseated. And then an increased incidence of post-operative ileus due to opioids specifically binding the mu-opioid receptors in the colon. So you might be thinking at this point, it sounds like a lot of good stuff. Maybe it's just one study. Maybe they just embellished their results, made some stuff up. Maybe it wasn't that good. There's been several meta-analyses over the past 20 to 25 years that have looked at all of these. I pulled just a few of them. You could read for probably several days just how beneficial these protocols can be. So 2 meta-analyses looked at randomized controlled ERAS protocols and revealed a 50% reduction in overall complications. And then a study in Canada looked at a similar reduction in length of stay, 11% reduction in complications, and they reported about $2,800 savings per patient. So then the question is, does this really just apply to colorectal surgery, or can we implement this in every surgical patient and patients coming in for same-day procedures even? So there's multiple ERAS protocols that have been developed over the last several years, and these enhanced recovery protocols have been modified or tailored to every specific type of surgery, from gynecologic surgery to orthopedic surgery to thoracic surgery, even to outpatient procedures and emergency surgeries. And all of them report similar positive results. So then the question is, if this is really that good, why aren't we doing it? And a lot of it has to do with how surgical care is delivered in the United States. Surgical care is very fragmented in nature. The only person who's really present for the entire duration is the surgeon. Everyone else is kind of met for a brief period of time along the way. Everyone ultimately has the same goal, but a very focused time and a very focused amount of impact in the process. So from the pre-op nurse, the anesthesiologist, to the recovery room, to the post-op management on the floor. Another reason is it takes a long time for literature to reach current practice. So some studies report up to 15 years for changes in clinical practice after the evidence is published within the literature. The other thing is, a lot of us think we're better than we are. I'm one of them, probably. And that our current care is good enough as it is. So within some of these studies, the authors asked colorectal surgeons specifically, how long do you think your length of stay is for your colorectal procedures? And they all said 3 to 4 days. They went and pulled all the data, and their length of stay was actually 6 to 7 days. And there's a lot of reasons for this thought process. Probably part of it is, once the hospitalist takes over and manages the patient after they're done with their acute phase of surgical care, it's probably a mental disconnect, and you think, well, the patient's going home, and don't always follow up specifically on what day they're discharged. If you asked a room of anesthesiologists, how many of you think you practice in the top 10% of your field, about 90% would raise their hand. It's not possible, but we all feel that we do a good job, and we want to do a good job for our patients. The other reason ERAS protocols haven't been implemented everywhere is that they're multidisciplinary. They involve every aspect of the care process, and they're expansive protocols. They're very labor intensive. They require continuous education of staff as staff leave, as new staff come on. They require a continuous audit of the process. So you have to look at the process over and over and over again and figure out what's working and what's not, get rid of what's not, and reincorporate what is. And then you have to have some form of leadership that is consistently pushing this. In many of the studies, they talked about these protocols being implemented and having great success for several months to years, and then slowly the protocol stops being followed, and then they go right back to their similar length of stays and complications. So the other big reason they're not implemented with success is that it requires a high degree of compliance in order to have noticeable improvement or documented outcomes. So you have to have 70 to 80% of compliance in order to have significant improvement and significant increase in outcomes. So you can't just do the pre-op portion or the intra-op portion and not do the post-op. You can't just decrease opioids and not have patients getting up out of bed. So there's a high degree of compliance that is required in order to enact change. The other thing that the majority of the studies notice is that the more compliant you are, the more outcome improvement you get. So if you can surpass that 80 to 80% compliance, get to 90% compliance, you have even better outcomes. So now we'll talk briefly just about what typical ERAS protocols look like. So from a preoperative standpoint, you want to optimize chronic disease states to the greatest extent possible. Be sure they're adequately beta blocked if they're on beta blockers. Be sure their blood pressure is well controlled so they don't show up the day of surgery with significant hypertension that could end up resulting in renal, acute kidney injury or other issues like that. You also want to attempt to enhance their physical status as much as possible. There's several studies that talk about helping patients even just get up and mobilize around their home. That has significant impact on their surgical stay. Do a nutritional screening. Majority of patients, a large number of patients come in and they're nutritionally deficient, don't have enough protein in their diet. It's going to affect their healing post-operatively. And then smoking cessation, It's been highly discussed for years and years, and it's one of the hardest things that we do as physicians. I make an attempt to try and talk to all my patients about it. I have a very limited role, and I encourage them to talk to their primary care physicians about it. In the American Journal of Surgery in March of this year, they looked at 220,000 patients who underwent elective hernia repair. Roughly 18% or 40,000 self-identified as current smokers, being people that smoked within the past 12 months. And current smokers had an increased likelihood of reoperation, of readmission, and death. Furthermore, smokers experienced an increased risk of post-op pulmonary complications, infectious, and wound complications. So a couple other aspects of ERAS protocols that are a little bit different from what we currently do. Structured pre-op information and engagement of patients and caregivers. We give patients information now preoperatively. This is a structured, organized handout that they get that specifically details all the aspects of the enhanced recovery protocol, so they know what their hospital stay is going to look like from the clinic visit to the pre-op visit to what it's going to look like the morning of surgery, what their medications are going to look like post-op, and what it's going to look like when they go home. Carbohydrate loading is another kind of newer developing aspect of the literature. And so what we found is giving patients 25 grams of carbohydrates, typically in the form of Gatorade, 2 hours before a procedure, significantly reduces their insulin resistance, prevents dehydration, helps stabilize their hemodynamics during the induction of anesthesia, and it also prevents post-op nausea and vomiting. So something as simple as a 95-cent bottle of Gatorade can have a pretty significant impact. And patients are a lot happier about it. The patients that we've instituted this in are significantly happier to be able to get up and have some Gatorade in the morning. The limit on this is roughly 2 hours before surgery. So what everybody might be wondering about that is, well, what about aspiration? We always tell people don't drink anything after midnight. Well, the ASI guidelines recommend 2 hours for NPO status for clear liquids. Gatorade is considered a clear liquid. So they actually did a meta-analysis of all these protocols that were using this and found that there was no increased risk of aspiration in patients who had these preoperative carbohydrate drinks. Prophylactic antithrombotics to prevent blood clots. A couple other aspects. Post-op nausea and vomiting prophylaxis. You want to do extensive prophylaxis as much as you can with multimodal therapy. The research on this really supports using various different methods of nausea prophylaxis, not just one single agent, so not just Zofran or ondansetron, but try and use a scopolamine patch or Decadron based on risks and the type of procedure to be done. The other aspect is regional anesthesia. What the literature supports is if there's a way to block it with local anesthetic and not have to give a systemic medication, do it. So if you can do a spinal anesthetic, if you can do any form of regional to block the pain response, then it really does provide a significant benefit to the patients. And then some of the protocols utilize intrathecal or spinal opioid medications and epidurals as well. So the intrathecal opioid is just a one-time injection of opioid pain medicine into the spinal space, and that gives patients 24 hours of pain relief and significantly reduces their overall opioid that they're administered. And epidurals initially were widely utilized, and more they have become shown less significance, except in the realm of thoracic surgery and large open incision abdominal surgery. They found that patients felt like they were tied to the epidural catheter and weren't able to get out of bed quite as much. But epidurals do provide significant pain reduction. Preoperative oral multimodal analgesics is another big change. So the idea behind this is to blunt the pain response and the sympathetic surge that happens as a result of pain. If you can block that before it happens, you can reduce some of the physiology behind pain with wind-up and other things that could result in chronic pain or at least severe pain. So gabapentin, celecoxib, and acetaminophen are kind of the three universally utilized within the literature. There's specific reasons to avoid, each, specifically Celebrex. You typically want to avoid that in patients that are going to have a CABG. It's shown to increase the risk of MIs in patients that have had a CABG if it's administered within 10 to 14 days. You also want to avoid gabapentin if you're administering it to somebody with renal failure, at least reduce the dose since it's primarily renally cleared. So gabapentin specifically binds to neuronal calcium channels. It reduces major side effects related to a lot of the opioid medications by reducing the amount of morphine equivalents that are totally administered. It's been shown, initially it was developed as an anticonvulsant. It's then branched out to neuropathic pain, and now it's widely utilized within the post-op pain realm. So it's similar to gamma-aminobutyric acid, but it actually doesn't bind that receptor. It binds calcium channels in the spinal cord. Essentially what it does, it just prevents release of excitatory neurotransmitters that you would have from any sort of surgical stimulus. And then Celebrex, or celecoxib, like I was talking about, is a COX-2 inhibitor. So you avoid some of the side effects of the non-selective, non-steroidal anti-inflammatories. And then acetaminophen, which is something that we use quite often, but no one really understands completely how it works. The mechanism is quite complex. It uses peripheral cyclooxygenase inhibition, central cyclooxygenase, and serotonergic issues. But the main thing about acetaminophen is that it works. And it sounds silly to tell patients that we're going to give you some Tylenol and it's going to help, because most people don't believe that, but it actually does, and the studies support that. From an intraoperative standpoint, the main goals are minimally invasive surgical techniques, so laparoscopic versus open whenever you can. Standardized anesthesia protocols so that everybody has a guideline to follow. And then avoid opioids as much as possible, particularly the long-acting opioids. So primarily these protocols support using short-acting opioids such as fentanyl, trying to avoid long-acting opioids like Dilaudid and morphine. Just a few more of the intraoperative aspects of these protocols. You want to have goal-directed fluid therapy. So before, we oftentimes administered large volumes of fluids to treat intraoperative low blood pressure. We found more and more that that's not really what we need to be doing. It's better to actually use vasopressors like phenylephrine and things that will constrict your blood vessels versus just filling patients up with IV fluids. Also attempting to remove surgical drains and NG tubes as quickly as possible, because that helps people begin to eat, begin to drink faster, and also to get up and move if they're not hooked up to a tube or don't have something that's causing them pain. Some of the intraoperative medications, it doesn't apply to a lot of people, but these are some of the things that we use. Decadron to help prevent post-op nausea, vomiting. It's also anti-inflammatory. Ketamine, NMDA antagonist, it significantly reduces post-operative pain, and it provides synergy with opioid medications, so you can give a significantly reduced opioid dose. And then IV lidocaine, which is used primarily in colorectal surgery. The infusion is administered intraoperatively, anywhere from about 1.5 milligrams per kg per hour up to about 3. So well below the toxic dose for it. And it provides a significant amount of opioid sparing in the OR. So people worry about IV lidocaine and toxicity. The toxicity reported in the literature is exceedingly rare because of the rate at which this is infused. And then Zofran and fentanyl, like I discussed earlier. So fluid management, kind of like we were talking about, we saw success in that University of Virginia study, decreasing their intraoperative fluids from 2.7 liters down to 0.8, and their total fluids to roughly, negative 0.1 liters or euvolemic upon discharge. And so that's where I think these enhanced recovery protocols can really have a big, big impact. So we have specific guidelines that are recommended. For open cases, we shoot for a 800 cc per hour open and 500 cc per hour laparoscopic. Different hospitals have different guidelines and protocols that they've set up. Some use intraoperative hemodynamic monitors where they actually look at variability and specific hemodynamic parameters prior to administering fluid boluses and that sort of thing. What you might be wondering about with these goal-directed fluid therapies are we not going to be causing acute kidney injury to these patients if we're limiting how much fluid they're getting? What all of these studies have reported is that there's very few increased rate of acute kidney injury in these patients. The University of Virginia study saw no increased rate of acute kidney injury despite the significant reduction in intraoperative and postoperative fluids. The main finding from all of this is that there's less concern with the volume of urine output intraoperatively and immediately in the immediate postoperative period. What we're most concerned about is actually changes in vital signs. So if they are tachycardic, if they are hypotensive, let's treat based off of that, not so much based on urine output. There's a lot within the surgical and perioperative period that can change urine output. So abdominal insufflation, for example, causes a release of antidiuretic hormone, which is going to cause you to retain urine. So that's just one example. From a postoperative standpoint, we are going to schedule our multimodal analgesics. So we're going to have scheduled gabapentin, scheduled Tylenol, scheduled Celebrex, or scheduled ibuprofen. That way there is a scheduled amount of pain control that happens all the time. And then you have a reversal of what we used to do. We used to do IV pain medicines for rescue. Now we're going to do oral pain medicines. And then if the oral pain medicines fail, then advance to IV. So there's a ladder that you have to step up before you get to the IV pain medicines. Early mobilization, the goal of getting patients out of bed the day of surgery as much as possible. Obviously, there's going to be limitations based on the type of surgery done, if they're still intubated, things like that. And then early oral intake. A lot of these studies are advocating oral intake in the recovery room once the patients are awake enough to follow commands and swallow. So quite a bit different. And then remove drains and catheters as quickly as possible. And then discharge planning is another big aspect of it. If you have somebody consistently working on discharge planning from the beginning, your focused goal is, we have this patient ready to go, now we have a place for them to go. That has really shown to be beneficial as well. So you don't want to have them all teed up to leave and then not have a place to get them to just because we didn't start planning a day or a day and a half early. And then continuous audit of the process, like I talked about. You really have to have, a lot of these studies actually have had people that have been hired or retasked within the organization to specifically continuously audit the enhanced recovery protocol. So their job is to see how these protocols are being implemented, ensure that they are continuously implemented consistently, and see what ways they need to be changed and modified. And also to educate staff on the appropriate way to implement and perform them. So for your specific fields or areas that you work in, what can I do as a primary care provider? Kind of like we talked about, optimizing everything you can from hemodynamic, heart rate, blood pressure standpoint, work on smoking cessation, nutritional status, exercise, physical activity. What can you do as a nurse? If you work in the hospital, assist patients early in ambulation. As much as you can, try and encourage them to get out of bed. A lot of patients are worried about getting out of bed because they think it's going to hurt, and it might to an extent, but if you can help them realize that it's going to help them in the long run and encourage them through the process, it also gets them more involved in their care as a whole. Limit IV opioid administration as much as possible. Try to use those oral opioids to get a more long-acting kind of basal level of pain control and go from there. Don't let patients just lie in bed. Really work hard on at least getting them sitting up in a chair on the side of bed, and then the protocols recommend 20 minutes of walking 4 times a day. So, physical therapy if needed, or family members as well to help assist them and patients doing that. So as a surgeon, what can you do? You can talk to your anesthesia group about enhanced recovery protocols if they're currently working on that. Talk to your hospital about it. You can help educate your patients. Adopt changes in post-op order sets as they get modified and developed, and attempt to reduce operative opioid prescriptions, and then attempt to limit your usage of NG tubes and surgical drains unless absolutely necessary. As far as our current implementation at St. Vincent's East, we began first with bariatric surgery population. I don't want to spend a lot of time on this because I know there's people watching from different facilities, but we just began with bariatric surgery population and are planning to expand it out to all surgical service lines gradually over the coming year to year and a half. So key points about this topic. Enhanced recovery protocols are focused. They're multidisciplinary. They're perioperative models that involve all aspects of the patient and all aspects of the patient's care. They're patient-centered with the patient as the focus of the protocols, and they're evidence-based, based on what the most recent literature has to report. And because they're evidence-based, they're frequently modified and changed and altered based on the results that you get. Enhanced recovery protocols are effective at reducing several things, primarily length of stay, cost, and outcome complications, with a concomitant increase in patient satisfaction. And then implementation is a challenging, time-consuming, laborious process that requires a lot of meetings and a lot of work. But I think in the end, it's ultimately well worth the time and the effort. Continued success depends on continued adherence to at least 70 to 80% of the protocol. And we have to continually evaluate and audit the process and our outcomes. So we have to have some sort of system set in place to do that. That's all I have. I'd be happy to take any questions.
What's the implications for like rolling this out for orthopedics? I didn't see that on your slide there. Is it different for orthopedics?
No, I think it's very similar. A lot of it I feel like we're already doing here, with regional blocks and regional techniques to as much as possible. A lot of it is post-operative. We really have to develop a specific order set for each post-operative patient population. We're working on developing those order sets as we go, and then what we're doing is essentially rolling them out to the specific surgeons and having whoever enters your orders, whether it's you or your PA or whoever entering your orders, enter that new order set, save it to their favorites and enter it.
You talked about carb loading before surgery. How much are you giving your patients? What kind of volume do they need?
25 gram carbohydrate. The max volume is typically somewhere around 20 ounces, 20 to 22 ounces. So most of the protocols and the literature supports somewhere around 20 ounces. And there is some new data coming out around maybe they need 25 grams of carbohydrates once around dinner time and then once 2 hours before surgery. But that hasn't really been fleshed all the way out yet. So right now we're just recommending 25 grams 2 hours before surgery.
So post-operative is the gabapentin, is that just a regular, like the dose? What makes you come up with a specific dose, like for bariatrics?
So the goal with gabapentin in general is to have a dose that is efficacious but also doesn't cause side effects. So the biggest side effects with gabapentin are dizziness and sedation. So we want to have a dose that is somewhere in the effective range but not high enough to cause dizziness and sedation in patients that we're trying to get up and mobilize. We didn't want that to limit their amount or their ability to participate in getting up and mobilizing. So the literature supports anywhere from 100 to 300. We went with the upper end of the range because we feel like most patients tolerate it pretty well. Kind of similar to the preoperative dose, a lot of different protocols at different places, like Hopkins uses 600 milligrams of gabapentin pre-op, we use 900. It's just kind of the literature recommends anywhere from 600 to 900 pre-op, 100 to 300 post-op. We've kind of gone on the higher end of all those.
And then, sorry.
Yeah, it's fine.
When you said a structured pre-op information, do you have anything that is there that you can look at to help maybe develop something from another practice or something, someone else that's done this? When you said, about teaching the patients and getting them involved, that gives them from the start to the end and everything. Do you have anything that I could look at or reference?
We have two one-page synopsis papers that just talk about the basics behind enhanced recovery, what it is, and this is what to expect pre-op, intra-op, and post-op. We don't have anything specifically tailored to each individual service line.
So we just develop it and go by those guidelines. Okay.
All right. Thanks so much for everybody's time. I appreciate it.